Sí. Okay. Okay. Boleh ya. Okay. Good morning, everyone. Welcome to today's hospital CME sessions. I'm Dr. Q from Departments of Dermatology, and the title of my CME topic is Psoriasis Beyond the Skin. This is the outline of my presentations. So firstly, I will briefly touch on what is psoriasis, then followed by the epidemiologies, causes, and pathogenesis of the disease. Then I will focus on the comorbidities related to psoriasis. Following that, I will briefly touch on the treatment option available in our country. Then I will present case scenarios, and finally, I will have this interactive quiz, okay, to test our understanding and to reinforce the key points of my presentations. So let's begin with my presentations here. What is psoriasis? Psoriasis is a chronic inflammatory skin disorder characterized by sharply demarcated scaly erythematous plaques. Occasionally, it may present with sterile pustules. The condition is non-contagious because up till now, there are still people believe that psoriasis is because of infections and it may spread to others. And it is also non-malignant, means that there's no chance for psoriasis to have malignant transformations to cause any forms of cancers or malignant tissue. Then it is non-allergic, so it's nothing to do with all the pantang here and there. And lastly, it's non-curable, but it is manageable. So how frequently do you expect to see a patient with psoriasis in clinical practice? So based on the current clinical data, psoriasis affects about 1 to 3% of world populations, and the prevalence varies greatly among different countries, from 0.2% in China up to 4.8% in Norway. As far as I understand, there has been no population-based prevalence study on psoriasis in the country. However, what we have observed so far is that there was about 2 to 6% of yearly new dermatoclinic patients in Malaysia have psoriasis, and up to 9.5% of the skin clinic patients at Hospital Kuala Lumpur are affected by these conditions. So how do we recognize or diagnose psoriasis? Actually, it is a clinical diagnosis. So we can recognize psoriasis through various characteristics. This includes the symmetry of elevated erythematous plaques, where we can see from the photo here, with the presence of coarse, thick, and silvery white scales, as well as they always come with a well-defined edges. Additionally, if the psoriasis involves the scalp, you may see that the plaque lesions extend 1 to 2 cm beyond the hairline and may exhibit Koebner phenomenon, where new lesions form at sites of skin trauma, at the skin trauma or injury. So the photo at the bottom of the slide here shows that there is a presence of a Koebner phenomenon here, where the psoriatic plaques are actually arranged in a linear form, okay, likely secondary to scratchings. So I would like to share a few photos in the following slide for our audience to guess which photo shows psoriasis. The first photo on your left is a gentleman with multiple thick and scaly plaques on the lower back, as well as the gluteal regions. So is this a psoriasis? Then the photo on your right shows multiple hypopigmented macules and patches on the upper back. If you notice, there's also erythematous rest located at the lower back here. Then close-up view. You may see there is a presence of erythematous plaque with a prominent rims or border at the peripheries and with some central clearings, and the lesion is intensely itchy. So again, the question is, it is psoriasis. So the answer is quite obvious here. The first photo shows typical chronic plaque psoriasis, while the second photo represents a case of a pityriasis versicolor, which is known as panau in Malay, with a concomitant tinea infection at the lower back. Next, what is the most striking features in these two photos? And again, which one is psoriasis? I think the answer is also quite straightforward here. The photo on your right is a case of scalp psoriasis, as the psoriatic plaques have extended beyond the hairline, like what I had mentioned in earlier presentations, and the lesions are much thicker compared to the photo on your left. The diagnosis for the first photo is actually seborrheic dermatitis, which is often known as dandruff. However, the tricky part is that sometimes you may argue that the first photo actually is an early manifestations of the psoriasis at an early stage. And this might be correct in some situations, you know. And there's also a condition known as a seborrheic where both seborrheic dermatitis and psoriasis occur concurrently. So therefore, to confirm the diagnosis of psoriasis, a thorough history taking is necessary. Ask about the family history of psoriasis and also look for other features of psoriasis in the patients. Then what about this photo? There are rashes in periumbilical region in both photos. There are lesions in the right photo. The lesions in the right photo have a thicker plaques and are more scaly and erythematous. So I think everyone here have no doubt that this is a plaque psoriasis. And looking at the photo on your left, it is actually a case of allergic contact dermatitis secondary to nickel exposure of from the belt buckles. So it is actually not a big deal to make a mistake sometimes, especially during the first encounter. We can always treat the patients and follow up them for progressions. And a good history is again a must. So other than the typical chronic plaque psoriasis, there are also other subtypes of psoriasis. These include palmoplantar psoriasis, which only involve the palms and the sole, and of course the scalp psoriasis, which is often mistaken for severe dandruff. Guttate psoriasis, and the guttate also stand for raindrops, as what we can see from the photo here. It is common in younger patients, teenagers, especially after a streptococcal infections like sore throats, okay? And there are also another subtype known as inverse or fractural psoriasis. For your information, typical chronic plaque psoriasis actually is more common at the extensor area, but sometimes we do get patients who have psoriasis develop on the fracture regions. And this is often mistaken as a tinea infections or candidiasis because they affect the skin fold as well. Sometimes the psoriasis may worsen involving the whole body, more than 80% of the body surface area, and it is known as erythromic psoriasis. And another spectrum of the disease is pustular psoriasis. Both erythrodermics and generalized pustular psoriasis are considered as our dermato emergency. The patients have to be admitted for not only topical treatments, and also we have to consider put them on systemic agents. So pustular psoriasis can further divided into the generalized types and the localized types. Under generalized types, we have annular pustular psoriasis and also acute generalized pustular psoriasis, which is also known as wound jumpers. Under localized pustular psoriasis, we have acrodermatitis continua haripua with a near involvement, and also palmoplantar pustular psoriasis. So if there's a near involvement, there will be pittings, leukonychia, clumblings, if they are affecting the near matrix. What if they are affecting the near bed? Then you will find subunger hyperkeratosis, onycholysis, or splinter hemorrhage. Just for your information, those near changes are actually not specific to psoriasis. They can also be found in other conditions, like you will see pitting in the case of severe eczema, alopecia areata, and sometimes you may find leukonychia or onycholysis in trauma, near fungal infections, and infective endocarditis is often associated with splinter hemorrhage. But however, there are still useful features that we can try to look for patients with psoriasis, especially when we have doubt about the skin changes. Then what about joint? So if there's a joint involvement, the outcome of the joint damage is often very severe and devastating if left untreated, like what we can see from the first photo here. And there will be no reversal once the damage is done. So it's actually very important for us to find out is the psoriasis, whether it's involved the joint or not. Moe and Wright have actually classified the pattern of psoriasis arthritis into following the IPJ joint arthritis, which involve the distal joint of the fingers and toe. Then asymmetric oligoarthritis, it affects usually less than 5 joints. For symmetric polyarthritis, it involves multiple joints symmetrically, just similar to our rheumatoid arthritis. Then for arthritis mutilans, it is characterized by severe deforming and destructive arthritis, and what we can see from the photo here. And while spondyloarthritis, or also known as axial arthritis, involve the spine and sacroiliac joint. So when I run the clinics, I always get these questions, okay, especially from a patient who is newly diagnosed with psoriasis. They always come up with the questions is, are you sure this is psoriasis? Why me? Why not other persons? And since there's no one in the family having the similar problems. So to answer that, the causes of psoriasis are multifactorial. It is primary and immune-mediated disorder with a polygenic predispositions, meaning there are multiple genes contribute to its formations. For genetic factors, there are around 30% having a positive family history, especially among those with a childhood psoriasis, up to 70%. Additionally, there are 40 susceptibility loci identified with HLA-C0602 being the prominent one, contributing to 50 to 60% of the susceptibility. And HLA-C0602 is also associated with early onset of psoriasis and gutted psoriasis. Environmental factors also play an important role here, such as trauma, infections, streptococcus, as I mentioned earlier on for gutted psoriasis. Medications, for example, beta blocker, anti-malaria, certain antipsychotic like lithiums, withdrawal steroids, as well as obesity, smoking, alcohol, and even psychological distress can also play a significant role in the onset and exacerbation of the disease. So I just want to highlight that the immune dysregulation in psoriasis mainly involve a few important cytokines here. So now we are regioned into the molecular level of the pathogenesis of psoriasis. So what are the important cytokines here are TNF alpha cytokine, interleukin 17, and also interleukin 23, which promote excessive skin proliferations and inflammations. Therefore, these molecules have become the targets for our biologic treatment in psoriasis now. So do you think that psoriasis is just about the skin and the joints or maybe the nails? The answer actually not. It is more than that. And this is the highlight of my presentation today. Looking at this slide, the impact of psoriasis goes deeper than the skin. 2/3 of the patients treated with biologics have more than one manifestations and comorbidity, such as cardiometabolic syndromes like hypertension, obesity, ischemic heart disease, and diabetes mellitus. Skin in psoriasis is only a cosmetic manifestations of these complex underlying systemic inflammation processes. And we always relate this with something known as a psoriatic march. So what is psoriatic march? It is a concept that psoriasis as a chronic inflammatory conditions may occur before the onset of other related conditions such as the arthritis, metabolic syndrome, fatty liver, cardiovascular problems, and other systemic inflammatory disorders. This progression suggests a cascade of inflammatory processes that can affect various organs and systems in the body over time. So when the psoriasis remains uncontrolled or severe, there is a higher likelihood of the patient developing the associated comorbidities. And the concept of the psoriatic march is further supported by recent evidence suggesting that psoriasis and its comorbidity share the similar genetic backgrounds and pathogenic pathway mediated by the pro-inflammatory cytokine, which I mentioned earlier on, which are the TNF alpha, interleukin 17, and interleukin 23, as stated in these diagrams. So overproductions of these pro-inflammatory mediators can migrate into the systemic circulations, potentially inducing a systemic like the insulin resistance, endothelial dysfunctions, increase the oxidative stress, increase angiogenesis, and hypercoagulations. And this will lead to the inflammations and cardiovascular damage. So individuals with severe psoriasis have about 2 to 3 times higher risk of developing metabolic syndromes, which include obesity, diabetes, dyslipidemia and hypertension. And this is further supported by our local data from our Malaysia psoriasis registry. And the patient with psoriasis also face a threefold increased risk of developing MI, especially at a younger age. And the life expectancy of the patient with severe psoriasis is reduced as much as 3 to 4 years as compared to the general populations. Additionally, these patients have an elevated risk of having lymphoma and non-melanoma skin cancer. But this is not the direct malignant transformation from the disease itself. It's just a risk factor. And at the same time, there's a higher incidence of depressions and inflammatory bowel disease. Renal disease is also a concern here, with a twofold increased risk of CKD and a fourfold increased risk of end-stage renal failure. Psoriasis can also have a profound impact on the patient quality of life. We may have no idea what the patient have gone through if we are not part of them. So this was a study conducted in 1998 to assess patient perspective on the impact of psoriasis on their lifestyle. The most frequent symptoms experienced by the responder were scaling, 94%, itching, 79%, and skin redness, about 70%. Up to 39% reported that psoriasis cover more than 10% of their body surface area. Only this, almost 80% of them reported that psoriasis had a negative impact on their life. Specifically, 88% feels that the disease would worsen, 81% experience feelings of embarrassment, and 75% feel unattractive. So why do patients care so much about the symptoms and suffer from these emotional disturbances? Simply because psoriasis leads to misconceptions, and the patients fear those with psoriasis due to lack of understanding. The people started to reject those patients with psoriasis out of the field and eventually lead to these neuropsychiatric disorders like depressions, anxiety, difficulty at work, and etc. So true enough, from the study, there are about 54% of them suffered from depressions, and 10% of them even contemplated suicide. So this is something I would say new. It was published in 2021, about 3 years ago, by Wang et al., where he brought up this theory of the gut-brain-skin axis. We all know that psoriasis can lead to depressions, and depression can worsen the psoriasis. The inflammatory cytokine produced in psoriasis are actually about the similar as the cytokine produced in depression, just like what I mentioned for the metabolic syndromes. So they share the similar inflammatory mediators here. So you have these vicious cycles, and this suggests that these two diseases may be related. Meanwhile, psoriasis and depression can also dysregulate the gut microbiota and increase its permeability to the inflammatory cells. So it is all connected. And of course, we need to conduct more study to prove their relationship. So what about psoriasis and schizo? This is a systemic review published in last year, studying on the risk of schizo in patients with psoriasis. The study concluded that there is an increased risk of schizo in individuals with psoriasis, and the risk of schizo is significantly higher in children with psoriasis. They also noted that females with psoriasis are more likely to have schizo compared to males under the similar conditions. In order to explain the relationship between psoriasis and schizo, Yang et al. Found that patients with schizo have a higher risk of developing psoriasis because of the SOR1 gene. And this SOR1 gene on chromosome 6p is considered a major locus for psoriasis vulnerability, and schizo can be linked with chromosome 6p on the locus close to these SOR1 genes. In addition, there's another hypothesis proposed by the clinicians that the inflammation of the CNS may contribute to the development of schizophrenia because there's microglial cells in the brain activated by the Th17 cells. These Th17 cells can be found in psoriasis, and they produce the TNF alpha locally, so indicating their involvement in the neuroinflammations. So if the hypothesis is true, we can probably use biologic to, such as interleukin-17 inhibitor in this case, to treat both psoriasis and schizophrenia at the same time. So how do we manage psoriasis, since this is a highly visible disease and brings so many distress to our patients? So first, we have to assess the severity of psoriasis before starting the treatments. This can be done by measuring the maybe the body surface areas, or PASI, also known as psoriasis area severity. It is important for us to pay attention to the impact of psoriasis on quality of life using the instruments like the LQI. So body surface area assessment is a method used in our practice to quantify the extent of involvement of skin conditions. It can be used in any skin conditions not particular to psoriasis, and actually it's very simple to perform. What we need to do is just to use our palms, not our palm, actually it's the patient palms, to assess the extension of the skin problems on the patient. So one palm size, including the fingers, is equal to 1%, and we should keep the BSA less than 10% in our clinical practice. And this is what the PASI score looks like. It is something more objective than the BSA. And to be honest, it is something nice to know for everyone here. Then this is the reference to guide us on how to give score based on the patient presentations. Ideally, the target PASI is also less than 10. DLQI is a widely used questionnaire in dermato to assess the impact of skin diseases on a patient quality of life. So this questionnaire consists of 10 questions covering various aspects such as the symptoms and feelings of the patient towards the disease, daily activities, leisure, works and school, personal relationship, and treatment. The total score ranges from 0 to 30, with a higher score indicating greater impairments of quality of life due to the skin conditions. We also should keep the value below 10 in our practice. So in Malaysia, there was about 40% of psoriasis patients score a DLQI more than 10, which means psoriasis has a very large impact on their quality of life. This number is worrying, as it might indicate that our treatment is not sufficient enough to help our patient to overcome the disease. And sometimes the DLQI may not be proportional to the severity of the skin disease. This discrepancy could be also result from you can find these recalcitrant psoriatic plaques in those highly visible areas such as face or the private parts. Even with a very low BSA, like maybe just a 1 or 2%, actually it can bring a very great distress of patients because they're simply located at the area that it can be seen by the patients or the partners. So a high DLQI is often associated with depression and anxiety. I think everyone have no doubt with that. So this chart is indicating that psoriasis has a high disease burden, negatively affect the patient quality of life. And actually, if you're looking at the chart here, the result is comparables. You have a comparable impacts on quality of life similar to other terminal diseases. So in short, according to the international consensus and our local guidelines, the ultimate goal when managing psoriasis is to ensure all measures like our PASI, BSA, DLQI remain below 10. Okay, please remember this. Psoriasis treatment modality can be categorized into several categories, including topical treatments, like for also phototherapy, systemic medication, and biologic treatments. So for phototherapy, for topical treatment, sorry, it is always our first line approach. So under topicals, we have protocolalytic agents like salicylic acid, topical steroid, which is the main workhorse in our clinics, vitamin D3 analogs, ditranol, which is not available in Malaysia, and of course, emollients. Under phototherapy, we have UVA and UVB. Then following that is systemic medications. Methotrexate is an immunosuppressive agent that can slow down the skin cell turnover. Acitretins, cyclosporine, they also have a similar mode of actions. And there's a newer agent here known as apremilast, which is a phosphodiesterase 4 inhibitor that help to reduce inflammations. And of course, systemic steroids sometimes for only certain specific condition. Don't simply use steroid in psoriasis because it might flare up the disease. So systemic steroid is normally indicated in the case of like severe pustular psoriasis or severe arthritis. Last but not the least, biologics. So the choice of treatments depends on the several factors here, such as the severity of the disease, the extension of the skin conditions, whether is there a presence of organ involvement like our joints or maybe the eyes and etc. And of course, never forget about the patient preference and the potential side effects. So treatment plan often individualized based on these factors, and it should be a shared decision between the patient and the clinicians. So as what we can see here, there are numerous topical agents available for psoriasis, but unfortunately, due to time limitation, I'm not going through them one by one here. Then based on Malaysia registry, topical monotherapy was the only treatment given in 74% of the patients. While for phototherapy, only approximately 2.8% of psoriasis patients receive photo in our country. Narrowband UVB is the key player in phototherapy because it is well tolerated with a very minimal systemic side effects. The downside that the machine is very bulky, as what we can see here, and it is not widely available. So for Kelantan, phototherapy machine is only available in our hospital, HRPZ, and the other one is located at Hospital Korakrai. So because of that, it's actually very inconvenient for the patients who have to come to a hospital 2 to 3 times a week for at least 2 to 3 months just to complete one cycle of treatments. So due to this, the treatment, the default rate, I would say, is high, which contributes to the lower percentage of patients going for phototherapy. Then what about systemic treatments? So based on the chart here, 14% of patients receive systemic therapy, meaning methotrexate, as it is an very effective agent, first-line agent in treating both skin and joints, and has shown a good evidence in reducing the risk of cardiometabolic syndromes. As for acitretins and cyclosporins, they are also good in treating the skin, but not for the joint. So biologics have become increasingly popular in recent years. They utilize this bioengineered protein designed to target those cytokines which I mentioned earlier on, the TNF alpha, interleukin 17, interleukin 23. These treatments are currently available in both in injectable form, either sub-Q or intravenous infusions. They are typically indicated for moderate to severe psoriasis, with the latest agents like the interleukin 17s and 23 inhibitors capable of helping our patient to achieve clear to almost clear skin. The current trend is actually gradually shifting towards early initiation treatment with the aim of modifying the disease, which means we are not only satisfied with the skin clearance, now we want to modify the disease so that our patient don't develop those comorbidities which I have mentioned earlier on. And for the new agents like interleukin 17 and 33, they even offer a better safety profile compared to the older generation biologics. They have less risk of, I would say, cancer, less risk of cardiovascular side effects, and also less risk of having TB. So photo at the bottom of the slide show a 27-year-old man affected by moderate to severe psoriasis on his back. As what you can see from photo A, there's extensive psoriatic plaque there. And 3 months later, after he was given these interleukin 23 inhibitors, there is a complete cutaneous clearance. So this is how effective the biologic is. And the problem is biologics is a price. It is very expensive. And for information, the 6-month therapy may cost as much as half the price of a MyVica. And access to biologics is not easy for doctors and patients because government hospitals typically have limited quota. So to start biologics, one need to apply TPP, okay? And each application lasts for only 6 months, which is often insufficient for our patients. So unfortunately, not everyone who needs biologic can access them, which means we are under-treating our patients. So of course, we hope for increased access to biologic to improve our patient quality of life and to bring smile to their face. So let's come back to the reality. So what is the usage of biologic in Malaysia? If you look at the table here, the utilization of biologics is very low in our country, accounting for only 0.7%. And hopefully we can increase the biologic coverage in the near future. So this table reviewed the list of biologics available for psoriasis, which highlighted agents indicated those currently available in our country. So we have a TNF alpha inhibitor, such as adalimumab, and I believe our rheumatoid colleagues, they are also using etanercept and infliximab in their clinics. Then followed by interleukin 12 and 23 inhibitor, ustekinumab, and 17 inhibitor, there are secukinumab and ixekizumab. And hopefully we'll have a broader and bimekizumab come into our country in the next few months or years. Then guselkumab and risankizumab belongs to the interleukin 23 inhibitor groups. And lastly, spepsolimab and imsidolimab, they are the interleukin 33 inhibitor specifically designed to treat severe pustular psoriasis. So let's see how effective biologics are and whether anti-psoriatic treatments can truly modify the natural history of psoriasis comorbidity. So with increasing data, biologics and MTX may prevent arteriosclerosis and lower the risk of cardiovascular disease. This publication from cardiovascular research, not dermato research, cardiovascular research in 2019 also highlighted that intensive treatment of psoriasis using biologic may have a positive effect on its cardiovascular comorbidity. The biologics managed to reduce the total plaque burdens as well as the non-calcified plaque burdens, and the p-value was significant. So our real-world data comparable with the study result we have reviewed so far. So according to the SOLA registry, which is something similar to Malaysia psoriasis registry with a larger scale and quite famous worldwide as the registry, it actually concluded that biologic therapy was associated with reduced risk of all-cause mortality and cardiovascular mortality in patients with moderate to severe psoriasis, regardless of treatment durations. And actually, the outcome is very promising here. And MTX also reduced the risk, but its benefit only became evidence after 1 year of treatments. So this finding highlights that the importance of early and sustained systemic therapy to reduce mortality risk. So 6-month treatment with biologic is simply not enough. So now let's focus on the neuropsychiatric disorders with psoriasis. So based on this systemic review, biologic agents for psoriasis have shown to improve depressions as compared to those who is not using biologic agents of phototherapy. Then in year 2000s, there's a study also reported significant improvement with both psoriasis and schizo in 2 separate patients after introduction of antipsychotic agents like haloperidol and conventional antipsychotic agents. And similarly, Chaudhry et al. In 2020 showed that low-dose MTX had potential antipsychotic effects in patients with schizo, which indicate the theory of T-cell involvement in schizo. So in contrast, certain drug use for psoriasis has been reported to have a negative impact on the cause of psychosis. An Italian study reported that worsening psychotic symptom in a patient with psoriasis and schizo a few weeks after initiations of the cyclosporine. And Kaufman et al. Also reported a manic episode in a patient with psoriasis following treatment with etanercept. On the other hand, a key series by Mara et al. Showed that one patient with bipolar disorder and delusion experienced good and excellent long-term efficacies and safety during the treatments with circuitumab, despite the patient is concurrently on the therapy like lithium, because lithium is known to exacerbate psoriasis. So till date, most of the data regarding psoriasis treatments and neuropsychiatric disorders mainly come from case report and case series. So of course, I hope that we can have more RCT focusing on these aspects in the future. So as a dermatologist or physician caring for patients with psoriasis, it is essential to take a proactive approach, which means the involvement, we need to actively screen patients for metabolic syndromes, for example, hypertension, diabetes, or cardiovascular disorders. And at the same time, not forgetting to assess their neuropsychiatric conditions for issues such as depressions, anxiety, and schizo. So I would like to share a case scenario here about a young lady with a severe psoriasis. She's a 28-year-old lady with 1 child, has been battling chronic plaque psoriasis since she was 10 years old. Her late father was actually our clinic patient as well. And he was previously on a biologic adalimumab for severe plaque psoriasis with joint deformities. So for the patients, she came to see us at the age of 18, and where her body surface area was about 40% at that time. The treatment timeline can be traced from 2015 until now, which is very long. Topical therapy is always there as part of the treatment therapy. And in June 2015, when she first came to see us, she was started on MTX with PSA of 40%. By January 2016, which was about 8 months after the MTX, her PSA was still around 30%, not much of improvement. Because of that, we decided to add in phototherapy on top of the MTX. So about 6 months after the combination therapy, her BSA finally reduced to approximately 10%. But however, phototherapy was stopped in January 2017 due to lack of further therapeutic effects, with her BSA ranging around 10 to 20%. And in May of the same year, she was switched from oral to subcu MTX because of the GI side effects. This is actually very common for MTX. And her BSA was about 20% during that time. And these changes managed to improve her BSA further down to 5%, which is very good. She discontinued the MTX in February 2018 because she was getting married and planned to have baby. at which point her BSA was 10%. Methotrexate is actually contraindicated in pregnancy because of the teratogenicity side effects. Unfortunately, about 1 month after stopping MTX, the psoriasis started to flare up. Her BSA went up all the way to 30% by the end of March. Cyclosporine was given for only 2 months as the patient was not compliant to the treatment. The reason why we choose cyclosporine in this case because it is safe in pregnancy. Anyway, in September 2018, she moved to Sedang and was only on topical treatments. By August 2020, she had returned to Kelantan when she was at 32 weeks of her first pregnancy with a BSA of 10%. Unfortunately, she experienced a psoriasis flare about 6 weeks after the delivery in October with her BSA exceeding 80%. So she was considered at the stage of erythroderma. So it is a dermato emergency. However, she declined systemic treatments due to breastfeeding and was discharged against medical advice. She went back to Sedang after that with only topical therapy. Then the patient again moved back to Kelantan in September, about 3 years back, and she presented to us again with erythrodermic psoriasis plus pustular eruptions. So things are getting more and more complicated. And for these episodes, there are few possible triggering factors, such as there was a history she was being treated for right leg cellulitis in early September prior to the flare of the disease. In addition, the patient was out of medication for almost a month and she was given a course of IV hydrocort when she was at the ED in Klang Valley. The cellulitis, missed medications and IV steroid could be the cause of the psoriasis flare. So 1 month later, when the infection had completely resolved, anti-X was restarted at the dose of 7.5. And subsequently, she was transferred to Hospital Pasir Mas in November due to a logistic issue. The patient was again returned to our clinics in November 2022 due to the psoriatic flare. And then we then started to apply biologics agent for her, secukinumab. There were a few more flares after that. Then in May 2023, she went through a divorce, which appeared to be a significant stressor for the psoriasis. Following this, something was not right. She began defaulting her TCA and frequently missed her medications and eventually refusing biologics, even though we had successfully gotten her the secukinumab. And she even stopped her MTX treatment altogether. So what happened in this year, February this year, she was admitted to psychiatric ward due to aggressive behavior that had been ongoing for about a year. She presented with worsening symptoms over the preceding 2 days, including pushing her mother to the ground, scolding and screaming at her mother's, and inability to manage herself and her child. She claimed that her family was threatening her. These symptoms raised the concern of neuropsychiatric manifestation of psoriasis or schizophrenia. She was treated with olanzapine and escitalopram and was started on MTX from our side for her psoriasis while she was in the ward. In April, she was readmitted again to the psychiatric ward due to the similar problem. We finally managed to put her on biologics secukinumab during the admissions after we have met up with the family member. And after 4 doses of biologics, her BSA was improved from 90% to 60%. Additional diagnoses include in 2021, when she was only at the age of 25, she already diagnosed to have obesity, diabetes, and dyslipidemia. So this is how she looks like before and after biologics. So the photo quality may not be optimal here because of the lightings. So, but for what we can see here, there are multiple psoriatic plaques on the abdominal wall as well as the limbs. Okay, and only after 4 doses of biologics, it takes out about a month. Then you can see there is a significant clearance of the psoriasis lesions. I think you can appreciate more on this photo. So from red skin to become normal skin, from scaly skin to become flawless skin. Of course, there's still some residual psoriatic plaques, but with biologics, it can bring down the disease activity in a very short period as compared to other systemic agents or the topical therapy. Okay, before and after. All right. And this is how her legs looks like before biologics and after biologics. So there is such a significant changes after she was given on the biologics. So issue and learning point from this case. A family history of psoriasis can lead to an early onset on more severe disease. Okay, knowing that her father is also one of our patients, also needing the biologic treatments. And psoriasis is associated with obesity, diabetes, dyslipidemia, and psychiatric conditions like schizo, especially if the disease is severe and has prolonged durations. Family support is essential in managing chronic diseases. Divorce was significantly stressful for the patients. In fact, what we noticed was the family supports were not really there. They are not really actively involved in the treatments. The family member often left her alone to attend our clinic TCA, and we need to really look into that. And biologics are effective for severe psoriasis, although their efficacy in treating schizo is still remain unknown. So take-home message. Psoriasis is a chronic immune-mediated inflammatory disease. Okay, it is not infections. This is not a malignant condition. This is just a immune-mediated conditions, and it is a systemic disease, but not only the skin problem. Moderate to severe psoriasis carries a higher risk of cardiometabolic complications, and we need to start treatment early. It is crucial to prevent irreversible damage. The treatment goal should go beyond achieving skin clearance to encompass overall disease modifications, addressing skin, joint, and indirectly cardiovascular and neuropsychiatric health. Okay, so I have done with my presentations. I think I will start with the quiz. So the question number 1 is, which of the following statement correctly describe the characteristic of psoriasis? So we have A, B, C, D here. So is there any volunteers? Kita ada hadiah kan? Tak ada hadiah. Oh, okay. You may try. Please.
D, non-contagious, non-malignant, non-allergic, and non-curable.
Yeah, the answer is true, D. So non-contagious, non-malignant, non-allergics, and non-curables. I think this is very important. We need to really spread out these messages to the public so that the psoriatic patients, they don't get isolated. Question number 2, what are the target responses for psoriasis treatment in terms of BSA, PASI, and DLQI? Less than 10, more than 10, more than 20, 30? Okay.
The answer is C.
Yeah, C. Yeah, correct. So it's very easy to remember. So everything less than 10. Okay, well done. Then the last questions. Which of the following comorbidity is not associated with psoriasis? Any takers? So I mentioned earlier on. Yeah, okay. Yeah, cataracts. So psoriasis is associated with cardiometabolic syndromes as well as neuropsychiatric disorders. So a little bit of advertisement here. Our dermato department is organizing a dermato update at the end of this month on 27 28 July. So it will be held at Renai Hotel. And we have invited renowned speakers from various places like KL, Ipoh, and Kedah, and more. There will be interesting topics and demonstration on common dermato procedures. So everyone is welcome to join us. You can find our poster on most of the notice board. So please scan the QR code and join us. And we are also going to celebrate our Psoriasis Day on 29th October for the first time in Kelantan State. Tentatively, there will be roadshow and maybe a fun run. So we will provide the details very soon. So please get ready to support another big event from our departments after our done updates. With that, thank you very much.
Thank you, Dr. Q Chen Hu, for the very good and informative presentations. And now I welcome any questions from the floor. There is no more questions. I would like to invite Dr. Wan Hasbi binti Wan Abdullah, Head of the Dermatology Department, to deliver the certificate of appreciations to Dr. Q Chen Hu. Please welcome. With that, we have come to the end of today's CME sessions. The upcoming CME will be presented by Dr. Sehana binti Ahmad Shukri, OMD specialist, with the topic of life at the end of the tube. So, thank you and Assalamualaikum warahmatullahi wabarakatuh.